Hi, my name is Boris Zaydiner. I am physician from Regional Cancer Center, Rostov-on-Don, Russian Federation. We will talk about one challenge of cancer comprehensive care. Fatigue is the most common syndrome experienced by patients during the cancer trajectory from diagnosis to the end of life. Cancer-related fatigue, CRF, is a cancer-related or cancer treatment-related distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion that is not proportional to the recent activity and interferes with usual functioning. The proportion of cancer patients experiencing fatigue reported to be between 40 and 100% of patients, depending on sample and methodology. The trajectory of fatigue may change in accordance with development of cancer disease with physical but not mental fatigue, reported to be more severe in patients with advanced stage of cancer. Some causative factors are more likely to be found in patients who are close to the end of life compared to cancer survivors or healthy individuals. Cancer patients invariably report fatigue to be a major obstacle in maintaining their routine daily activities. CRF has a significant negative impact on patients' physical, psychological, social, and existential spiritual well-being. This disorder diminishes a person's mood, cognitive performance, sense of self and security, ability to work, to participate in social leisure as well as other previously enjoyable activities, and to sustain meaningful relationships with their families and others. Depending on the cause and severity of the underlying disease, the effects of CRF can range from temporary indisposition to inadequate coping with everyday life and social withdrawal, all the way to the inability to perform one's job and earn a living, leading to economic hardship for the patient and an additional economic burden for society at large. Fatigue is more distressing and associated with impaired quality of life in patients with 2 to 6 months left in life, but during the last days and weeks of life, the association between fatigue and quality of life disappeared. The syndrome degrades social relationships. The physiologic, behavioral, emotional, and cognitive components of fatigue affect tumor progression by disturbing mood state, concentration, willingness to receive treatment. Fatigue impacts patients' concerns regarding their mortality and compromises their hope of fighting the illness. It also interferes with therapy compliance and even limits the active curative care. The detrimental impact on CRF on adherence to treatment was established. These disturbances cause the survival worsening and increased mortality. The relationship between symptom management and cancer treatment adherence has been identified as a priority for comprehensive care. In addition, CRF is underreported, underassessed, and undertreated. Therefore, encouraging patients and their families, caregivers, to report CRF is strongly recommended. Fatigue is common and debilitating comorbidity of cancer that results from a combination of psychological and biological drivers. It involves input from various physiologic systems, resulting in the subjective experience of mental, physical, and or emotional tiredness and lack of energy. In an effort to address what constitutes CRF, specific diagnostic criteria were developed and proposed. The criteria define CRF as a syndrome by the presence of the following specific symptoms: diminished energy, increased need to rest, which is disproportionate to changes in activity level, and related symptoms across physical, emotional, and cognitive domains. The experience of CRF involves multiple biopsychosocial dimensions, signs and symptoms. Pain and dyspnea, shortness of breath are most strongly correlated with fatigue. Physiological signs and symptoms induce anemia, muscle atrophy, physical weakness, and low aerobic capacity, sleep disruption, and hypothyroidism. Besides the latter, the key endocrine disturbance in CRF is believed to associate with hypothalamic pituitary adrenal axis. These effects can occur via alterations in glucocorticoid production, including dysregulated circadian profiles. Non-fatigue cancer survivors mounted a significant cortisol increase in response to acute stress, while fatigued survivors had a very blunted response and flattened cortisol slopes, having higher levels of cortisol at the end of the day than do non-fatigued survivors. Fatigue, like pain, is viewed as a self-perceived state and patient-reported outcome. Individuals may perceive fatigue as impaired physical performance, depletion of energy, a feeling of heaviness and tiredness or exhaustion, reluctance, being fed up, a need for reduced activity, a reduced motivation, including a lack of initiative, pessimism, expectation of negative outcome, not knowing what to do with oneself, and not encouraging oneself to do anything, and or mental fatigue. The latter can be expressed as a reduced capacity for attention and learning. Patients may describe fatigue as feeling tired, weak, exhausted, lazy, weary, worn out, heavy, slow, like they do not have any energy or any get up and go. When comparing the fatigue scores of cancer patients with those of other populations, or when comparing fatigue scores obtained before treatment and those obtained after treatment, an interpretation problem arises. Patient's perception or internal standard for determining his/her level of fatigue can change primarily as a result of treatment course. What has been perceived to be intense or severe fatigue before anti-cancer treatment might be left slightly fatigued after the patient has experienced exhaustion during treatment. The term response shift refers to such change in a person's internal standard for determining a level of functioning on a given dimension. Health professionals have included fatigue within concepts such as asthenia, lassitude, malaise, prostration, exercise intolerance, lack of energy, weakness. CRF probably starts in the skeletal muscles due to a progressive reduction of physical activity, sometimes with physical interruption. Research of chemotherapy receiving patients reported that chemotherapy always non-specifically targets skeletal musculature, especially the mitochondria, inducing adverse side effects due to low energy supply and high oxidative stress. Peripheral fatigue results from the depletion of energy stores, synthesis of side products, and decrease in muscle contractile capacity, which are related to immunological and genetic responses, while the brain is also critical as a central regulator of fatigue perception. Intracerebral monoamines, neurotransmitters such as serotonin, 5-HT, dopamine, and noradrenaline have been demonstrated to be associated with central fatigue. Higher 5-HT concentrations in the brain are stimulated by increased tryptophan levels and can also facilitate 5-HT's crossing of the blood-brain barrier, which affects locomotor performance. There is acceptance of the positive association between changes in brain activity and cognitive fatigue, and these connections typically occur in several areas of the brain, such as the basal ganglia and prefrontal cortex. Recently, tryptophan degradation and several cytokines and other pro-inflammatory mediators produced in response to cancer have been associated with fatigue. A positive correlation between fatigue and circulating levels of inflammatory markers was shown. Interleukin IL-6, interleukin-1, and neopterin values in particular were significantly associated with CRF. Activation of the immune system by infection, injury, or trauma leads to the release of pro-inflammatory cytokines and other immune factors, including receptor antagonists, soluble receptors, and products of cellular activation. These cytokines orchestrate local and systemic immune response, and mediate neural symptoms such as fatigue. Several of cytokines produce fatigue, malaise, fever, weight loss, and night sweats. For example, interferon produces neurasthenia, a neurologic fatigue suggestive of frontal lobe changes. This fatigue manifests as loss of motivation. Patients lack energy to accomplish even minor aspects of daily living, such as brushing their teeth. Varieties of distressing symptoms debilitate cancer patients and contribute to their profound fatigue. These patients often have low-grade fever that weakens them. Fever can be caused by infection or non-infectious etiology related to the cancer and mediated by cytokines: TNF, IL-1, 2, 6, IL-12, interferon, and others. Peripheral inflammatory cytokines can signal the central nervous system to generate symptoms of fatigue and other behavioral changes via alterations in neural processes. In the pretreatment period, the tumor itself may be a source for pro-inflammatory cytokines, while during treatment, cytokines may be produced in response to tissue damage from radiation or chemotherapy. In patients undergoing combined radiation and chemotherapy, the markers of inflammation were increased and associated with increases in fatigue as well as other prominent sickness symptoms: irritability, malaise, sleepiness, poor appetite, anhedonia, and social withdrawal, cognitive disturbances, and depression. This cluster is well known, called the sickness behavior. As a moving force of this disorder, cytokines were appreciated. High levels of cytokines appear to be associated with a greater symptom burden. Psychological responses to cancer diagnosis and treatment can also influence fatigue symptoms. In particular, the tendency to catastrophize, rumination, magnification, and helplessness, or engage in negative self-statements and thoughts regarding fatigue, e.g., I begin thinking of all the possible bad things that could go wrong in association with the fatigue. I tell myself I don't think I can bear the fatigue any longer, was associated with higher levels of fatigue during and for up to 42 months after treatment. Mood symptoms include depression and anxiety. There are social symptoms such as reduction in the patient's ability to participate in leisure activities and so on that were mentioned. The presence of depression is manifested by loss of interest, difficulty concentrating, lethargy, and feelings of hopelessness can compound the physical causes of fatigue in these individuals and persist long past the time when physical causes have resolved. Depression in particular is considered to be a contributor to fatigue, as fatigue and depression are strongly correlated in cancer populations. Feelings of depression may result from the fact that one has a possibly fatal disease, and a depressed state of mind may induce fatigue. However, depression couldn't only be a cause, but also a result of persistent feelings of tiredness. The association between these two constructs is complex. Fatigue is a symptom of depression, but may also precipitate depressed mood due to interference with social, occupational, and leisure activities. Loss of function, loss of energy resulting directly from illness or its treatment may have this adverse psychological consequence. Finally, in cancer, depression and fatigue may occur because both result from the same biological factors. The anxiety and fear associated with a cancer diagnosis and the impact of that diagnosis on a person's physical, psychosocial, and financial well-being are sources of emotional stress. Distress associated with a cancer diagnosis alone may trigger fatigue. Impairment in cognitive functioning, including the ability to concentrate, carelessness, forgetfulness, especially disturbances in short-term memory, errors while speaking, impaired perception, and slowest thinking is commonly associated with fatigue. The mental demands inherent in the diagnosis and treatments of cancer have been well documented, but little known about the concomitant problem of attention fatigue in people with cancer. Besides decreased attention span, some of the problems may be caused by the fatigue of directed attention. Cognitive fatigue may interfere with the use of social support. The pattern of fatigue associated with cancer treatment varies according to the type and schedule of treatment. For example, people treated with cyclic chemotherapy regimens generally exhibit peak fatigue in the days following treatment, then report lower levels of fatigue until the next treatment. However, those undergoing external beam radiation therapy report gradually increasing fatigue over the course of therapy of the largest treatment field. Few studies of people undergoing cancer treatment have addressed the issue of fatigue as a result of the emotional distress associated with undergoing a diagnostic evaluation for cancer and the effects of medical and surgical procedures used for that evaluation and for initial treatment. Although the clinical literature examining cancer-related fatigue in the pre-treatment setting is limited, several preclinical studies have tested the link between inflammation and fatigue. Let's list ICD criteria for CRF. CRF exists when the following symptoms have been present every day and nearly every day during the same 2-week period in the past month. A. Significant fatigue, diminished energy, or increased need to rest is proportionate to any recent change in activity level, plus 5 or more of the following: complaints of generalized weakness, limb heaviness, diminished concentration or attention, decreased motivation or interest to engage in usual activity, insomnia or hypersomnia, experience of sleep as unrefreshing or non-restorative, perceived need to struggle to overcome inactivity, marked emotional reactivity, e.g. sadness, frustration, or irritability to feeling fatigue, difficulty completing daily tasks attributing to feeling fatigued, perceived problems with short-term memory, post-exertional fatigue lasting several hours. B. Clinically significant distress or impairment in social, occupation, or other important areas of functioning caused by the symptoms. C. Evidence from the history, physical examination, or laboratory findings that the symptoms are a consequence of cancer or cancer therapy. D. Symptoms not primarily a consequence of common with psychiatric disorders, such as major depression, somatization disorder, somatoform disorder, or delirium. One more burden infers on patients' feelings to the caregivers. It's such feelings that are highly correlated with CRF mood components: depression, hopelessness, outlook. Improvement in CRF had a positive effects on the quality of life. Management of CRF is now being highlighted as a adjunctive cancer treatment and priority for comprehensive care in cancer. Early identification and symptom management has a key role in palliative care regarding the patient's physical, psychosocial, and existential needs. Fatigue should be recognized, evaluated, monitored, documented, and treated promptly for all age groups at all stages of disease prior to, during, and following treatment. Patients and families should be informed that management of fatigue is an integral part of total health care. Thank you for attention.